Okay, let's start. And the first talk in this session, crystal Janssen's peripherally inserted central line. The peculiarities of insertion process. Шановні колеги, перша доповідь буде постановка периферичного центрального венозного катетера. Доповідач Крістел Янсенс з Бельгії, президент асоціації BEVANET. Так. Please, Crystal, your talk, please. Thank you.
Good evening, everyone. Thank you for the introduction. As your colleague already told you, I'm a clinical nurse specialist in Belgium. I'm also a president of the vascular access network in Belgium called BEVANET. And now I will try to share my screen, and then we can go ahead with the presentation about PICC lines. Just a moment. Share. I hope you all can see this. And then we go ahead with the presentation. Okay, I already told that I'm from Belgium, and Belgium is a very small country in Europe. For those that don't know, you might know our products who are very famous, and is our Belgian beer, our Belgian waffles, the Belgian chocolates, and also our Belgian fries. In Belgium, Belgium itself is the federal state, and we have a Flemish part and also a French-speaking part. But our hospital, Leuven, is in the Flemish-speaking part, so in the north, nearby our Brussels capital region. So the red dot you see on the screen, that is our location of our hospital. Belgium has a lot of hospitals, but our university hospital is the largest one of Belgium. We have nearby 2,000 beds and almost 10,000 employees. And today I will talk to you about PICC lines. And in Belgium we insert for at least 10,000 PICC lines last year. And you see in our hospital the blue numbers are our number of insertions. So we almost inserted 1,500 PICC lines in our hospital in Belgium. So there are a lot of indications for catheters. I summarized some of them. For instance, we insert PICC line to give cytostatics to our patients, mostly the short schemes with a combination of radiotherapy. Also, we insert PICC lines for antibiotic therapy for several weeks, for instance, for patients who have orthopedic prosthesis infections or patients with cystic fibrosis. A third indication is the total parental nutrition. If a patient needs TPN for several weeks or several months, then we insert a PICC line. We can also use it for administer blood products. Everything we want to administer to our patient, all kinds of IV therapy can be given through a PICC line. The length of the therapy is determined which kind of catheter we choose, and if it is for several weeks until 6 months, then a PICC line might be a good indication. There are also some special indications. Normally we would insert just an acute central venous catheter for it, for instance in the jugular or the subclavian vein. But if a patient has a bad coagulation, that might be a bit riskful. So then it might be easier to put a PICC line in the upper arm so the bleeding can easily be stopped. And also if a patient has a surgery in the area of the head of the neck, or if he has severe burn wounds in the area of the head of the chest, then we might put in a PICC line which exit site is more at a distance and not nearby the surgery field or the wounds. And then the last special case I would like to add is a patient with respiratory problems. For inserting a central venous catheter, you have to put the patient in a Trendelenburg position, and that might be a bit difficult if the patient is short to breath. So a PICC line can be inserted when the patient is just sitting upright. Without any problem, we can puncture the vein. We don't need a Trendelenburg position, so that might be a bit more comfortable for patients who have difficulty with getting their breath. So there are also some contraindications for the PICC lines. For instance, there are some thrombosis or phlebitis or stenosis in the veins we are willing to use, so then we can't insert it, of course. If the patient has a history of thrombosis with previous PICCs or midlines, he has a 60% chance to get a new thrombosis when we put insert a new PICC line or a new midline. And also in patients with chronic kidney disease, we are careful to use the arm veins, because if we damage those veins, they can't be used anymore for an AV fistula in the future if the patient needs dialysis. We also avoid to put in the PICC line in an arm with lymphedema over an arm that is paralyzed, and also near infection or open wounds, or also we don't want to puncture in an irradiated area if a patient has already had radiotherapy in his history. So if you do decide to insert a PICC line, then we're going to do the insertion step by step, and I will explain you every part of it. So first, we want to position the patient's arm. Normally, we put the patient's arm in extension and in abduction. And if we want to insert a PICC line at the bedside of a patient, you also can bend him upwards, so he can lay his arm in his bed. So that's also an idea. And then we do a full assessment of the veins without tensing the tourniquet. So we want to have a good idea how the normal physiological situation is of the veins, just to have an idea how large those veins are and if they are suitable for the PICC line. If we take the anatomy, you see there is two brachial arch veins, and there is also a basilic vein and a cephalic vein. And we take also into account the arteria, the brachial arteria, and also some nerves in the area around it. So our first choice would be the basilic vein, because it's more localized, more separately from the artery and the nerves. And then our second choice will be the brachial vein, but there the nerve will be more close to, and also there is an artery nearby. And our third choice will be the cephalic vein. Most of the times the cephalic vein will be too small or too tortuous to insert a catheter. So most of the times we will go for the basilic or brachial vein. I already told something about it. We have to take into account the catheter vein ratio. So we have to measure how large our vessel is, just to make sure that the volume of our catheter isn't taking all of the space into the internal volume of the vein. We want only 1/3 of the inner volume of the vein to be filled with our catheter. So the blood flow won't be restricted, because if the blood flow is restricted and it slows down, then the risk for thrombosis is a lot higher. So we, just to make sure, if you want to insert a 4 French catheter, you at least need a vein with 4 millimeters, maybe 3 millimeters, but if you go smaller than that, then the blood flow will be restricted, and it might cause some problems in the future. So we insert a catheter who is just enough to do the job. Then we also use our zone insertion method. So we divide the upper arm in 3 parts, the red, the green, and the orange part. And the red part is around the elbow, so there is a lot of muscle contraction and compression of the catheter over there. We also have more blood return into the catheter, and there is also more risk of migration. So there is more bleeding due to the movement of bending the arm, and also because of it is near a joint, we think the catheter is less likely to be good secured. The dressing doesn't stay on as well, so we have a lot of problems if we insert a catheter in that area. Then the orange part of our arm is the area around the armpits. There is more hair growth over there, there is also more sweat, and there is a higher bacterial colonization over there, so it is less a less good spot because of the higher risk of infection. So the green part is in the middle of the upper arm, and that is the best location to insert our catheter. There is a better stabilization of the vein due to the position of the vein who is beneath the fascia, so we see less complications over there. Then once we picked the right spots in the middle of the arm and we choose the right vein, then we will mark our position of the ultrasound probe, and we will puncture our vein in and out of plane in the short axis position of our probe, and then we can go ahead with the procedure. Just make sure that the inserter wears a cap over all his hair, mask covering mouth and nose, and also has done a surgical hand disinfection, wears a sterile gown and wears a sterile glove. And then we will disinfect the puncture site with chlorhexidine 2%. That will be our preference. If it doesn't, if the patient is allergic to chlorhexidine, then we also can use iodine in alcohol as well. Let the disinfection product dry, and then we drain the puncture site and the patient, just to make sure that we have a sterile field where we can work in. We prepare our equipment, so we prepare the sterile table with all the materials like our catheter and the dressing, and also we cover our ultrasound probe. And then we visualize the vein again, and we administer the local anesthetic just to numb the skin of the patient. Then we perform an ultrasound guided puncture, and then we have some blood withdrawal, and we insert the guide wire with the floppy tip, and we remove the needle. Then we will insert the dilator. So first we make a small incision, just to make sure that the dilator goes in very smoothly. This might feel a bit awkward for the patient, but once this part is over, the most difficult and painful part for the patient is already passed. So then we advance the wire in the right position. So we check with fluoroscopy if the tip is near the atriocavial junction. And once we are over there, then we will measure the length of the wire and cut our catheter at the right length. We loosen the tourniquet and then remove the dilator and the guide wire. We leave the peel-away sheet in place and then insert the catheter itself through the peel-away sheet. Then we're checking again for the tip position of the catheter, and then we check if the catheter is full functional. So it's easy to inject fluid, but also easy to aspirate blood. And then we remove the peel-away sheet, so you can pull it in two, leave the catheter inside, and just remove the peel-away sheet itself. And then we have to secure the catheter, of course. There are two products I would like to demonstrate today. So first you have the Stetlock. It's an adhesible securement device. So you put the catheter in the device and close the two doors. And then later on, once the sterile drape is removed, you can secure it on the skin of the patient. And then there is another device, the Securicat device, which is a subcutaneous anchored device. So it's a device we bend in two and then insert in the insertion puncture site itself. and then this device will unfold itself again, and then we put the catheter in the device and close it with the cover, and then make sure it's secured very well. It's closed well enough, all the sides, and then you see it is anchored beneath the skin. So there are two devices, and don't go further into that, but there are the two most common used securement device for quick lines. And then once the catheter is in again, we just check once more if the catheter is full functioning again, and then the catheter is in. Now, I explained this procedure when we use the fluoroscopy, but what if you don't have fluoroscopy available? There are also some other techniques you can use to verify the central tip position of the catheter, because the central tip position is very important, as our colleague Margriet Stas will explain you later on in this presentation this afternoon. So another technique we can use is the intracavitary ECG technique. Is a setup where we measure the electric heart activity, and we use one intravascular electrode and 2 or 3 classical external ECG pods. If we see the vector of the ECG is going towards a specific electrode, then you see a positive deflection. If the vector is moving away from the electrode, then we see a negative deflection on our monitor. So we are following the amplitude of the deflections, and it will be increased with the amount of depolarization cells that are in the area. So the larger the amplitude, the closer we are to our source. So the smaller the amplitude of the deflection, the more away we are from our source. So if we enter the right atrium, then the amplitude will be at this highest level. So how do we put up this kind of thing? We have a patient and we have 3 electrodes. The yellow one is on the left upper arm, the green one is on the left side on the belly, the red one normally we put on the right shoulder, but now we will connect it with the switch box, and then the electrode from the switch rod we connect to the right upper arm. In the middle, where the letter B is pointed out, there is a connection to our intracavitary lead, and it might be connected to a clamp. That's one technique, or it might be connected to a saline syringe, the alpha guard. There are 2 techniques we can use. I will explain it later on. So if we advance our catheter into the patient, then we first arrive at the high superior vena cava, and you see that the P wave is a bit higher than in the superficial ECG. If we advance the catheter more into the distal superior vena cava, then it will be larger, and when we arrive at the right atrium, then we see that the P wave will be at this maximum level, the maximum P wave. If we would like to advance the catheter further, you will see that it will be bifocal, or it gets smaller again, then we are too far. So we're looking for the maximum P wave when we're advancing the wire. So how do we put this in practice with a PICC line? So first we do again a vein assessment, we mark the puncture site, we do an external measurement just to have an idea how long the catheter will be. So we measure from the puncture site until the mid of the clavicle bone, until the 3rd intercostal space. That's one measurement, and we write that down, and then we do another measurement from the puncture site until the sternal notch. And if we come from the right arm, we add 10 centimeters. If we come from the left arm, we add 15 centimeters. That's also one measurement, and those 2 measurements, most likely the length of the catheter will be between those 2 measurements. So what we do, we cut the catheter a bit longer than the estimated length, and then we will go ahead with the procedure. So we disinfect the arm, perform a puncture the vein, advance the wire, insert the dilator, and then if we use the guide wire, we insert the guide wire into our PICC line. We insert the PICC line, and the clamp is connected to our guide wire and connected to the switch box. And then we will follow what is happening with our ECG on the monitor. So you see the P wave is rising, and if you put a fluoroscopy next to it, you will see our maximum P wave at the right side will be at the normally two vertebrae beneath the carina if we check our fluoroscopy. So it's the same spot. Then we measure how long the catheter is still out, and we remove the catheter again, cut it a bit shorter, just to make sure that it isn't too long, and then we do the same procedure again, just to make sure that the catheter is in the right spot. So here you see again, first we see our normal surface ECG, we connect the clamp to the switch box, and then we see the P wave. Maybe it might be interesting to measure the external part of the guide wire, just to make sure that the guide wire in the patient is not going further than the catheter itself. So the guide wire is just at the tip of the catheter. Otherwise, our lengths will not be so accurate. So once we have our maximum P wave, the catheter is in the right spot. If necessary, you can remove the catheter, cut it at the appropriate length, and repeat the procedure, and check again if the P wave is at the right spot. Then we remove the wire and the PLOA sheet as we did in our other procedure I explained. We check for injection and aspiration, clean the inserted site, secure the catheter, and dress it properly. There is also another technique where you can use the saline solution. That is called the alpha guard. This is just a syringe that is filled with saline, with also a connection possible to connect to the switch box. So then we advance the catheter into the patient, and we inject 1 milliliter of the saline syringe that is connected to our switch box. We wait a bit for the signal to stabilize, advance the catheter a bit further, wait a bit for the signal to stabilize again, and then we will check what the P wave is doing. So that's how the procedure is done. We already should document a lot of what we have done. So what we are documenting is the type of catheter we have inserted, the number of lumens the catheter has, the diameter and the lob number of the catheter itself, which vein we have used, the length of the catheter, the total length, but also the external part, the tip where it is, so it should be at the atriocavial junction, and the type of securement we used. Also, if the functionality was good, we also document, and also if there are any problems during the procedure as well, we also document it. Why is it important? There are some legal aspects why it is important, but there are also vascular access in the future. Then it's interesting to make sure that we know what problems there occurred, and it's also important information for the maintenance afterwards. If there are some complications afterwards, we also can check what was the situation during the procedure. Are there any explanations who might explain what happened with this patient afterwards and what caused the complication we are now dealing with. So in conclusion, we evaluate what the need is before we pick the right catheter. We evaluate the veins of the patient, then we perform an ultrasound-guided puncture. We make sure the tip is at the right position at the atriocavial junction, and important is to have a team that is dedicated to insert those catheter make sure you do it as well as can, just to make sure that the nurses who are taking care of the patient with this line have an easy job to do. So here is our total team. We have our surgeons who are inserting the ports and the tunnel catheters and the PICC line as well. We have also a team who is taking care of the complication management. We have a colleague who is making sure all the patients are planned correctly. And then we have a nurse-led PICC team in our hospital, the only one in Belgium. 3 nurses who are very good trained and have skills to insert PICC lines itself together with our surgical team. So that was the presentation I would like to give. I don't know if there are any other questions from the audience that will be asked. So maybe I will stop sharing.
Thank you very much, Crystal. We have a few questions, and the most simple one, do you insert PICC lines in general ward, or you have some special places devoted to such procedure? And in case the ECG monitoring is not available, for example, in general ward, how safe is it to put such lines without ECG confirmation?
Yeah, mostly we insert it in the theater. And we use fluoroscopy, but if we go bedside, then they use the ECG technique. For instance, or intensive care, or patients who are pregnant or on a ward, and you can use any kind of monitor. We have an ultrasound machine with a monitor in it, so we only need the switch box. We don't need any special equipment. Any monitor can do so. If you have a monitor you can take with you, it don't has to be a special one, just a monitor who can read an ECG, maybe a small ECG one that is used to transfer patients from the intensive ward to theater, for instance, that also can do the job. So you don't need very expensive equipment, just some ECG leads and a small monitor will be enough to do the job. There are very fancy equipment you can use, but also just the cheap one will do as well. I don't know if that is enough answering your question.
Mm-hmm. Thank you very much. And next questions. How would you choose the personnel for your team? Who would like to work in such a team? Is it any special characteristics for nurses to be involved in such a nice team?
No. The most important thing, it doesn't mean what kind of degree you have, what kind of profession you are. The most important thing is that you are caring for your patient and you are willing to learn and to observe from one another, and just to make sure you want to do it well. That is important. Anyone can learn something like this. So if you have some kind of medical background, you can learn how to insert a PICC line. But it is important that you very engaged to it. So dedicated to do so you make sure that the catheter goes in well, that everything is done correctly, and you don't harm the patient, of course. If a patient has a high degree, maybe the best doctor and the highest level of education, if he doesn't love to insert a catheter, it will not be done right, because it takes no time for it, it goes too fast, and maybe doesn't have attention for the patient during his procedure. So if you love to do it, you mostly do it in the best way.
Okay, and the last questions. What is about patients? What is the most frequent patient diagnosis such catheters to be inserted? Do you know who is your clients from the patients?
Yeah, most of our patients are patients who need antibiotic therapy, because they are used for all kind of problems. I give some examples. That's the most common indication we use it for. But it depends on what kind of patients you are seeing in your hospital. If you're an oncology hospital, then maybe there are only patients who need chemotherapy. But in our hospital, we see most of our patients needs antibiotic for several weeks, and then we insert a PICC line.
Thank you very much. Crystal, if we have additional questions, maybe our audience would like to provide it at the end of this session. And with a great pleasure, I would introduce the next speaker, Dr. Thomas Ducci, the complicated vascular access. Please, Thomas.
Yes, good afternoon. I'm Thomas. I'm one of the oncology surgeons at UZ Leuven. So while we're talking about challenging vascular access, and I think we have to define it a bit, so we will be talking about actually mid to long-term central vascular access, because the central position of the tip is actually the part where most of the time it gets difficult. In our hospital, as Christopher already told you, the PICC lines are mostly inserted by a specialist nurse team. So for me, it's most of the time it's port catheters and tunneled Hickman lines. There are a couple of issues that can arise during insertion of a central line, and it depends on a lot of factors. So, of course, the operator experience will play a role, patient compliance, exit site anatomy, and some vascular challenges which we will discuss about. So first of all, operator experience. It's really important just to know a couple of different techniques. In a normal situation, about 95% of your catheters you will be able to insert with a standard technique. You can always do the same thing. But the other 5% you really need to be a bit flexible. In our hospital, we tend to use the venous cut-down technique. We are a surgical ward, so that's probably the reason. If you use a standard ultrasound-guided vein puncture, for me that's just as well. But it's important to know the different techniques to be able to get around some issues. Different tunneling techniques, you have to be able to use a wire to get around some corners if you get into trouble. So it's important to use a standard technique, but you have to know some other techniques just to get out of the issues. And it's also important that these standard techniques you use are adjusted so you try to keep the veins as intact as possible, because our patients and some patients will need multiple vascular accesses, and it's really necessary to preserve your vein beds to get into the vein. Just to explain a bit, in our hospital in general, for the Hickman catheters and the port catheters, we tend to do a venous cut down of the cephalic vein as a first choice. Then we do venous cut down of the external jugular vein, and as our third option, we do ultrasound-guided puncture of the internal jugular vein. Of course, you could also use a subclavian vein, also ultrasound-guided. We never use anatomical landmark guided punctures because it has more risks, and it's really easy to do it ultrasound-guided. It's a lot safer to do it like that. We tend not to use a subclavian vein because with the other three options we always get somewhere. And then if you have to avoid the upper vena cava system, you can go to the greater saphenous vein, femoral vein, caval vein, but we'll be discussing that a bit later on. So what I want to say first is that it's important to do a pre-op evaluation, because doing a patient history, checking, doing a clinical examination and imaging, you will probably be able to select the patients in whom your vascular access will be difficult. And you will be able to prepare for these procedures. We do most of our procedures under local anesthesia, so it's quite annoying if you start a procedure and you get into trouble. It might take an hour and a half, 2 hours. For a patient, it's very difficult to lay still for 2 hours on an operating table. It's really not comfortable. If you know beforehand in a patient that you can expect issues, maybe you can do some imaging and prepare for a solution already. For example, a patient history, if you have a patient who comes with a new colorectal cancer, he never had any surgery, then probably you can expect it to be quite easy. If you get a patient with a history like this, ovarian cancer started in 2003, she had multiple abdominal surgeries, okay, that's not really an issue. But if you look at the history, you see that she had multiple lines, port catheter in 2003, then multiple infections, intestinal failure with total parenteral nutrition for a long time. And then at the end, it gets a bit annoying with dysfunctions, and then you can really expect that you will get into trouble if you need to put a new catheter in here, and it could be useful to prepare. Clinical examination, so this is an example of a patient with a lot of veins on the thorax. You can expect that there will be some occlusion here on the cable vein or anywhere else. Patients who have skin disease might be quite difficult to find a good exit site. Pacemakers, leads sometimes make it quite difficult to get around to a good central position of the tip. For example, a tracheostomy, that's one of the indications where it might be useful to know how to do a cephalic cut down, just to get away from the midline. It's more sterile, it's quite easy, but the alternative could be the subclavian vein. And then the PO imaging, most of these patients will have some kind of PO imaging. Most will have a CT scan actually, but even on a radiography, you can see predict a lot of problems. This first patient, you see a very wide mediastinum. Probably there is a tumor there. The first thing that gets compressed is the vena cava. There's a very tiny, very thin-walled, it's low pressure, so it's at high risk to get compressed. It will probably be very difficult to get central access here with a good tip position, so I would ask a CT scan in this case. The second case is actually the case of the history you saw before. So she has a catheter inside, but you see that the tip is actually quite high up. It's much higher than it needs to be. And if we zoom in, you can actually see on the radiography that there is structure that follows the course of the vein, and it's actually a calcified sleeve of the catheter, which causes an obstruction. Discussing the solution a bit later on. And the last image is an image where you can see a vena cava superior stent. And actually this also is quite nice to know beforehand, because this will, you will actually have to choose one of the two sides to place your catheter, because you will never be able to pass a catheter through the innominate vein here. And for the ones of you who are very attentive will maybe notice that this is actually the same patient as the second radiograph. You can also see the calcified sleeve running about here, so this was actually after the treatment. Patient compliance is something we can really help, so we do most of our procedures under local anesthesia. So they're awake, try to get them in a comfortable position. In contrast actually to what Crystal told, I think it is really possible to put a central line even in a sitting position. It's really not necessary to put a patient in Trendelenburg position. If you have an ultrasound machine, you can definitely puncture a patient sitting upright, put some blankets between the knees. We give our patients actually a warm blanket. It's really nice for them, and it gets them relaxed. And I think anxiolytics and general anesthesia is rarely necessary for a central access. The next issue we might encounter is the exit site. There are a lot of issues that might arise. We recently had a discussion about the best choice in cutaneous lymphoma in our center. Patients who have burn wound scars, even previous surgery might direct you in choosing another exit site. An example is esophageal resections. make it quite difficult to do an internal jugular puncture on the left side because the esophagus might be in the way there. This is one example of a patient with a cutaneous lymphoma we saw quite recently. So she has a lot of exudating wounds, which make it difficult to choose a side. So the inside of the arms are both affected, which make it a bad position to the PIC catheter. The thorax is actually completely affected also, so that's quite difficult to choose a side here. And there are some tricks that you might use to get to a better exit side. The first one is tunneling. It's a really useful technique to know. And you can tunnel actually to kind of anywhere you want. This is a picture of the previous patient with the lymphoma who had the wounds on the medial side of the arm. And you see that we tunneled the catheter to the lateral side where the skin is nice and intact. These two patients didn't really have skin issues, but it was rather a compliance problem. They pulled out their catheters. A very young child who had a port catheter placed on the back so it would not pull on the fusion lines. The way we do our tunneling is you can just use a tunneler, but sometimes these actually is just a rod they use to make the tunnel. Sometimes they are quite big and a lot bigger than the catheter itself, and that might cause some issues. And we tend to also use infusion catheters to make the tunnels. As you see, you can just use an infusion. If you have a 5 French catheter, you can easily use the 14 gauge infusion needle to make your tunnel and put it through. It's really easy, it's really versatile, and you can get your exit side almost anywhere on the body with these techniques. It's really useful to know. Another issue might be the catheter fixation, and as Crystal already told, we use two systems. The first one is a glued system, and the second one is a Securacat. And also in these patients with cutaneous problems, using the Securacat might avoid having to put glues on the patients. Also with patients who have allergies to glue, this is really a nice system to use, which might help your patients. And then another thing is that you might choose your puncture site depending on if you have, like the last patient, this is also the patient with lymphoma, but another catheter placement. You might use the femoral vein or another axis to get away from the skin problems and tunnel to another position. Anatomical issues might also cause some problems. Obesity and pacemakers might be technically challenging, but if you have an ultrasound system, you can always get to the vein. Aberrant anatomy and vascular complications of aberrations might make it a bit difficult. The first thing is anatomical variation. So these are two radiographs of the thorax. They look kind of the same, but they're actually completely different. And you can't really tell by looking at the images. But the first one is an arterial puncture of the left subclavian artery. And the right image is a persistent left superior vena cava. That's one of the problems with doing an anatomical puncture of the left subclavian. If you have an arterial puncture, you will get this image, but it might actually be something else. So be aware that this might be just normal and actually a good position for the catheter. So if the left subclavian left cava superior is persistent, we just put the tip of our catheter also 2 vertebrae below the bifurcation of the brain. These two images show the same. So this is a persistent left superior vena cava with complete, with no innominate vein, and you see the catheter coursing down in a good position. This happens in about 1 in 2,000 patients, and you should just know that it exists, and we see it once or twice a year. so you don't be very surprised. If you put the catheter in a good position, it functions perfectly. There's not really a high risk of thrombosis or anything else, so it's usable. Situs inversus, of course, is extremely rare, and most of the times when I saw it, it was probably the radiologists who just inverted the images. So that's most of the time. That's the issue, and not really a situs inversus. And then some vascular challenges. So again, the patient history I showed you earlier. So a patient with multiple catheters who needed a new catheter because of the dysfunction. We saw the image with a catheter which is too short. You can already expect that there will be an issue here by the catheter. The initial catheter is not long enough. We asked, I showed you this before. She also had a CT of the thorax, and here again you can actually see the catheter which is too short, it's not in the atrium. And you can see the calcified sheet from the previous catheter after an infection. It's actually quite rare to see such a calcified sheet. And another thing which might alert you on a CT scan, although it is without contrast, you should be quite sure that there is a stenosis here. And that is the very large azygos vein, which is the collateral formation from a chronic vena cava superior stenosis. So most of the time it's azygos vein, but it might also be a mammarian veins, which are enlarged. The muscle veins might be enlarged depending on the position of the stenosis. We asked our interventional radiologist to do an angiography which confirms the stenosis, and then we continued by doing a combined surgery. We took out the catheter, changed it for a sheet, which was actually a 6 French sheet. It was a 6.5 French Hickman catheter, which was inserted for TPN. The radiologist inserted a 9 French sheet in the femoral vein. They snared our wire and then pulled it through the stenosis. They did a dilatation, put a self-extendable stent in there, and then we changed for a new catheter over the wire through the stent. The reason we use a double axis is twofold. It's actually easier to put the stents in coming from the femoral vein. Plus, you need a 9 French sheet to put in the stent, while if we do it from the jugular vein, the hole in the vein will be too large to put in the Hickman catheter afterwards and get bleeding complications. So it has two advantages to it like this. So this is Professor Malou, one of our interventional radiologists. We find them to be very useful, and we do a lot of cases together in these complex anatomical variations. Another case, also with a central stenosis, but this time it's mediastinal B-cell lymphoma. You see the images here, so we already saw the X-ray of this patient, very wide mediastinum as expected. We did a CT scan, and you see that there is a stenosis, a complete occlusion almost of the superior vena cava, plus the innominate vein and the truncus brachus collicus. It's really not a good idea to put a catheter in this patient coming from the internal jugular or the subclavian vein. This will only give issues, problems. And then you actually have two choices in this patient. Chose to go for a definite solution, so we put it in a port catheter coming from the femoral vein with a port on the medial aspect of the thigh. So femoral axis is not really, if you know how to do an ultrasound guided puncture of a vein, it's actually not that difficult to do a puncture of the femoral vein. You might also do a venous cut down of the saphenous vein, but that's a bit more complicated, so we tend to do an ultrasound guided puncture of the femoral vein, and then tunnel the catheter either to the medial side of the thigh or we might tunnel it to the lower abdomen for catheters for long-term TPA. A similar case, just to show you that there are alternative solutions, is also a lymphoma. The patient had a stenosis on the superior vena cava, and in this patient we went another way. We put in a midline catheter just to give the first lines of chemotherapy, and then after 2 months you see that the tumor actually vanished completely, and this is typical for the lymphomas. So that's also the reason why in lymphomas we do not choose to put in a vena cava stent, because afterwards we give them chemotherapy, the tumor vanishes, and then the stent starts walking everywhere in the cava system and migrates to the atrium, which gives very serious complications. So to stent or not to stent, in which situations do we choose for a stent? Well, I already discussed it a bit. In almost any situation you can choose a vena cava stent, but be a bit careful with tumors which might shrink a lot after the treatment. That's especially for lymphoma, for which we do not place a stent. Then you can choose to do a temporary midline access or put a long-term catheter from the femoral vein. Just remark about the stents. If you have a patient who already had a stent previously, you have to be a bit careful on the side to choose to put your central venous access from the superior veins. There are two options for the stents. We never use double stents, so we always only stent either the brachiocephalic vein or the innominate vein, so the left or the right side. The reason is that it gives a very good patency, and the resolution of the symptoms is as good as putting in 2 stents. So we used to, like more than 20 years ago, we put in 2 stents, one for the brachiocephalic vein and then one for the innominate vein, but it gave a lot of complications because of the high load of iron in the vessels, and gave a lot of thrombosis. And we saw that putting in 1 stent is enough. But if the stent is in the brachiocephalic vein, it's actually quite impossible to come from the left side. The same accounts for stents. In the innominate vein, the right side, you cannot pass through the studs of the stent. So try to avoid that. And then I still have 2 slides on more rare access options. If you do not have a superior vena cava access possibilities, like in this patient, complete occlusion, everything is closed. The inferior vena cava is also occluded. If nothing passes, then you can choose for translumbar access. It's a bit more exotic, so you use CT scan. The radiologist punctures the cable inferior vena cava and then puts in a catheter. That way, if you want to go a bit further, if this is not possible, there have been some case reports. One review on direct intraatrial placement dialysis catheters, but of course this is pretty exotic. So in conclusion, I think you should really prepare well. In 95% of the cases you will be able to place the catheter without any issues. 99% you will be able to put them without a lot of preparation. But it's in the 1% where it is really difficult that you need to be prepared to do the right imaging beforehand. And if you do it under local anesthesia, it's very nice to know before you start the procedure that you will get into problems. Try to be comfortable with multiple techniques to avoid these problems, and do a good planning and imaging, and talk to your interventional radiologist. Thank you very much. I'm happy to answer your questions.
Thank you very much, Thomas. We have a question. In case of considerable prolongation of procedure, do you have the cut point? For example, the time or the quantity of attempts when you stop and postponed such position, or for example, next time perform under anesthesia and so on. Do you put such cut points in advance, or you decide when to stop during the procedure?
Yeah, we really decide during the procedure if we really get into trouble, but that's quite rare. And as I said, most of the cases you will be able to predict in which patients it will take long or it will be difficult, and if you're prepared, you can do almost any procedure in under an hour. Even the caval dilatations and stentings we do under local anesthesia with a switch of the catheter, and it all happens in under an hour. I would prefer doing everything under an hour, but sometimes we use our assistants place a lot of catheters, and it sometimes goes up to 2 hours, but I would prefer not doing that.
Continue for this question, do you have some indications for procedural sedation when such catheterization has to be performed under deep sedation, for example, or is it enough to do it under the local anesthesia?
We do not have the possibilities in the OR room we use for more extensive anesthesia, so we really do almost everything under local anesthesia. For children, we have a team that does some anesthesias using Calinox or a bit more extensive anesthesia, and that might be helpful in younger children, but most of the time we do them under general anesthesia.
Okay, thank you very much, Thomas. Maybe further question at the end of the session, and with great pleasure we introduce next speaker, Margaret Stas, with problems that occurs with long-term venous access. Please, Margaret.
Is it working? Do you have an image? Yeah.
Yes, we have. Please proceed.
Thank you for the invitation and also for the acceptance of the changes in the program, avoiding that we had to travel in this period to Kiev. So I will talk about the malfunction of the long-term vascular access devices, and as you see, there are a lot of people working on this field, and I want to thank them all. And so you see their name here. There are surgeons and nurses working really hand in hand, and that makes, I think, the group stronger. So I have no disclosure for this presentation. As Crystal already said, there is a huge amount of catheters and accesses inserted in our hospital, and the big lines reaches their higher number in 2018. After that, there was also a shortage in inserters. That's why the number is more limited. That is the green line. That is the number of ports we insert. These are the midlines with a difficult start up, and here the tunneled catheter for specific indications such as hematology patients. We work in the frame of a multidisciplinary team, but the number of accesses inserted by surgical oncology, who also started with these procedures, is still the highest now. Now, I'm going to talk about the functional description of the different access. What can you do with them, and what if they present problems? So in the normal situation, the reason for which we are inserting a vascular access device long-term, essentially, is to have an easy injection of medication and fluid, and also an easy aspiration of blood. If it is like that, then the patient scored 1. I also want to repeat that it's a safety concern to control this before injecting blood products or medication which can be harmful if there is any extravasation outside of the venous system. If we see that the injection of a product can be difficult, or there is a difficult aspiration or no injection possibility or aspiration possibility, then the patient receives a score 3, and we really have to do something for that before embarking in a vascular access. So a normal injection is 1 milliliter of fluid without resistance, and an aspiration is to get easily 3 milliliters of liquid. There is also a X score. When usually we ask to the people who are using the access to indicate what the state is for the injection and the aspiration, and if they forgot it or could not do it, then they are classified as in X and as X about their functionality. We tried, that was developed a few years ago, and we saw that there was a good diagnostic accuracy between the nurses and the specialists who developed this classification, and everyone could easily learn what it meant. So that's what I'm going to show you step by step what we can do if there is a problem, mainly from aspiration, is a AS2 or AS3 classification. But before that, I will go more in detail. We made a crossover of we put together all the aspects we could find, and the normal is in 1 AS1. If you go to something more difficult, you will have a resistance for injection or difficulty for aspiration, but you still get something in movement, then it's into AS1, into AS2, in 1 AS2 in orange, and then in red that is resembles all the cases where at least one of the function injection or aspiration is totally impossible. Now, for a safe use of your intravenous access device, you have to check again, it's a repetition, the ability to draw blood before the use. If you do not get at least 3 milliliters of blood easily withdrawn, there is no proof that a catheter tip is located in the patent vein, and there is a risk of extravascular injection and tissue damage. Now, there are 3 main types of catheter occlusion. The big intraluminal clog, then it's impossible to inject or to aspirate any fluid. You can have an extraluminal occlusion by a fibroblastic sheet attached to the catheter with some valve effect of the sleeve here. And that makes that it's easy to inject but not to aspirate blood. And then you have also the huge sleeve extraluminal with venous thrombosis. Sometimes it's still possible to inject some fluid here which will come up around the catheter and then into the vein if the clot is not too big. And this is, but here usually the aspiration of blood or other liquid is impossible. That's why it's qualified as into or sometimes 3, and certainly as 3. One of the things which is the most important, my colleague already told about that, is the catheter tip position to keep a good functioning system or device. And Schwartz already more than 20 years ago showed that it was very important to have a good position of the catheter tip, otherwise you will face a reduced device-specific duration or get complications, such as here shown in a picture of a removed superior vena cava with a catheter in place and a lot of fibrous tissue. This is coming from a patient who died with his catheter inside too, and who needed further examination of the dead. The importance of the tip position is also given for tunnel catheters, as you see in this series. The catheter tip has to end here at the junction between the superior vena cava and the right atrium, and who further that you are, who higher is the incidence of thrombosis. If the catheter is a little bit too deep, it's not an issue, but it may not really bump on the heart valves. Now, is it needed to control the catheter tip position in each patient who receive a central line? I should say yes. Even if you are very experienced, it's always safer to prove that you are right before you get problems. It's also a kind of respect, and mainly that for the patient, and it's very important also in all the teaching centers, because looking at a picture afterwards can comfort you that what you did is correct. Now, it was not proven till now, I think, that it's better not to control or only use anatomical landmarks for all inserted catheters, but we do have data on the fact that any control is better than just an anatomical landmark. What we can do is a post-operative chest X-ray, but it's not the best choice. At that time, the patient already is gone from the theater, and if the position of the catheter is not correct, you have to begin the whole procedure again. You can do a perioperative fluoroscopy, what we did during a very long time, till we had more or less dangerous techniques for evaluating the place of the catheter tip. Perioperative, it's not dangerous, only we prefer to avoid that because of the X-ray radiation, and we prefer then to get other techniques. One of these is the intravasal electrogram, already shown with the ECG technique. You also can use a transthoracic echography. It's a good technique, it's not invasive, but you need more training with the intravasal electrogram. You also can do a transesophageal ecography. Usually that happens in general anesthesia for patients requiring heart surgery and not just for the fun. You also can do a right supraclavicular ecography, where you put the echo probe above the clavicula on the right side, and you see where the catheter ends. Of course, for patients with a left-sided superior vena cava, you have to change the side. Here there was a question: is it really needed in center with a single expert devoted to the central venous access? It was claimed, but I'm a little bit scared to use that. Now, the position of the catheter tip in our hospital is very important, and we really try to show to our trainee how important it is. And these are the result of survey we did over 5 years, where the nurses of our catheter team received nearly 4,000 requests for malfunctioning in catheters, or the catheter is just clogged, we don't know with what. Some patients received additional chest X-ray, and from this chest X-ray we could see that the location of the catheter tip was the optimal, and that's essentially in our hospital it's about 3/4, and there was a suboptimal position in 25% of cases and 1.3% malposition, real malposition. From patients coming from elsewhere referred for a larger problem than initially expected, and the half of the patient had optimal catheter tip position, and the number of suboptimal and malposition was increased and is also significant. So in this patient we had more need of replacement and reinsertion of a new device. I told you about the X-ray, and you saw already some pictures, but for us, irrespective of the type of the central line is only central when it comes with its tip at least at the junction between the superior vena cava and the right atrium. For that, you can have you can be confident in several landmarks on the chest X-ray. That's when vertebral height, if you have a straight course of the catheter last centimeters parallel with the vertebrae for a height of 3 vertebrae, the tip should be well located, and it's about also 2 vertebrae beneath the carina or 2 centimeters beneath the lower border of the right main bronchus. You also saw this picture about the ECG technique, which was implemented here in 1998, first as a comparative study and then a randomized control trial showing no inferiority, and it's now still for the ports, anyhow our standard technique. If the catheter is initially a little too short when it's inserted, as you can see here in a patient who is lying in supine position for his procedure, it will definitely be really too short when the patient will stand up. It is known that the change of position will give an elongation of the structure in the mediastinum, and the catheter will apparently move upwards for about 2 centimeters, and that can also be a cause of clotting and thrombosis and more sleeve formation. So if we talk about malfunction, sometimes if you have only a limited blood reflux in a catheter, the pressure changes due to pressure changes during catheter connection and disconnection can be helped or prevented by the use of a positive of neutral pressure needleless connector on the IV lines. If there are already large amounts of blood who came into the catheter, that can be due to catheter compression and decompression exercise for instance, during heavy sporting, and it can also be a reflux in the catheter due to an empty infusion bag, which is not discarded, so the blood can move into the infusion. The precipitates in the catheters can be prevented by adequate manual flushing of saline after each injection with a push-stop technique and 10 milliliter syringes. We can help that also for the special case of the use of contrast dye injection for CT scan. The patient in our hospital receive a rinsing of with an infusion pump of the device, and we added to that 20 milliliter normal saline after each use for CT. And it's best to do that with temperature at least at room temperature, otherwise you will have some more clogging of the contrast dye. You see a picture on the right lower side of this slide, blood clots in the port chamber, and that can be the reason of a strange inconvenience, the reverse ball effect, where the aspiration of blood is possible but not the injection of liquids, and herefore you have to use thrombolytics to solve the problem. Please note that most of these events here are preventable. Beside the internal problem, there are also extraluminal causes that can be prevented. For instance, a clamp on an infusion line that is not open, so you cannot inject anything. The catheter length is already addressed, and you also can have a secondary migration of the catheter in form of kinking, looping, teeth displacement, due to intrathoracic pressure change, cough in children, crying in children after a CT power injection procedure. So we try with pickers to avoid extreme exercises. The shortening of the catheter due to an accidental pull out can be prevented at least partly or mainly with sutureless anchoring device. So the nurse during the catheter insertion place care can move the catheter without risk of dislodging. The problem of the fibroblastic sleeve of thrombus developed around the catheter tip is already treated. It's important and underscore the importance of the location of the catheter tip. Sometimes when you're using port catheters, mainly those with fully embedded in silicone, there might be a problem of puncturing a zone which is not really the septum, and you are not really feeling that. Here an example of a port who was turned upside down, and you see the needle for the puncture going through the wrong opening. But in general, the chosen needle is too short, and it's better to just remove it and try with a longer needle. There was a habit in the beginning in the past century, to lock the ports and tunnel catheters, Hickman and Browiak, with normal saline containing heparin in order to diminish the risk of intraluminal clot and occlusion of the catheter. In 2006 to 2009, we performed a randomized controlled trial comparing heparin, 300 units for 3 milliliter, with normal saline for the locking of the port catheters. And as you see, when we look at the difficulties of blood withdrawal after a heparin lock or normal saline lock, the normal saline was even better than the heparin. Also, we saw a diminishing of the incidence of catheter-related bloodstream infection, and all patients were followed for 118 days. And this randomized control trial led in our hospital to a shift in the whole catheter care and became moved to heparin-free hospital. Now, if you have an obstruction, to prevent an obstruction, there are different possibilities of flushing. Flushing is important, but some type of flushing are more important, more effective, essentially, than others. Here it's a trial in vitro in France, where colleagues inserted albumin in catheters, and always the same amount, and then they were trying to get this albumin by flushing the catheter. You can do that with a continuous flow of 6, 12, 18, 24 hours, but you see that with this quite passive and gentle way of rinsing, you will need 24 hours before you have removed 80% of the albumin in the catheter. You can do that also with a continuous flush with a syringe of 10 milliliter, and it's already faster. But if you do that with a pulsed flow, the push-stop technique, you will gain much of time and also of efficiency. So now in our hospital, the standard of already for a few decades, the best way to flush the catheter is to use a 10 milliliter syringe filled with normal saline and a quick flush with the pulse technique. If the patient has a total occlusion of the vascular access system, we can try the three-way stopcock technique to remove the clots. No, sorry. Hoe kan ik terug naar achter? Ja, en dan try this. Daar. Okay. A little video will show you, I hope, how it works. Yeah. What you need with this technique is Actosol, that is urokinase. That was the first and only product which was reimbursed for this indication. So now the nurse is preparing a three-way stopcock with one 10 milliliter syringe with this Actosol, and the other one 20 milliliter syringe to perform the aspiration of the content of the catheter. now you're trying to fill the catheter, the syringe, but it's not working. And then the nurse will connect the lumen of the catheter with the syringe with medication, hoping to get step by step 1 drop or 2 drops of product who could cause a thrombolysis in the catheter lumen. And repeating this a few times till all the urokinase is used can help to open the catheter. Sometimes you have to repeat it, but the failure of this technique is very low, and it's really exceptional to have to replace the catheter because this technique didn't work. The fact that the aspiration is manual and it will not give an pressure on the lumen of the catheter, and the urokinase is just passively aspirated by the catheter, emptied from its air. Some manipulation of the catheter pressure and release can also help to mobilize the clogs. And suddenly there is no resistance anymore for the injection, so we inject the rest of the product and also with the saline to keep it open. After a quarter hour, if it didn't work, you can repeat it. So what we use as treatment for that's the first choice when you have a catheter occlusion. If it is in S3, such as for the previous patient you saw, the urokinase is the best. It's 15,000 units for 3 milliliter of aqua. And if you have a good injection and no possibility for aspiration, you have to check if the catheter tip is properly located. And if it's okay, you can drip 40,000 units of urokinase during 1 hour with a pump. If you suspect lipid residues, it's better to use sodium hydroxide. If it's acidic precipitate, HCl. If it's calcium phosphate as well, and if there are alkaline precipitate, it's better to use NaOH. Now the CNAS matters also for the gradation of the malfunction, and you can follow the patient first with normal function of the catheter and then impaired efficiency, and then sometimes total blockade. For the urokinase, the use is also, the dosage are different. If you have a multi-lumen access device, kind of Hickman catheter with more than 1 or more lumen, we use 1.5 milliliter, that means 7,500 units for injection and hope to declogging the catheter. If you have A multi-lumen catheter, you only use 1 lumen at a time, and if you have a port catheter, we insert 3 milliliters, that will say 15,000 international units. For the children, smaller than 10 kilograms, we use a little bit less concentration, and also that's given with a mini bag of 15 milliliter of saline. Now, these things cannot happen in some patients with very low platelet counts, with recent bleeding, neurosurgery of recent punctures. Now, if you look at a patient who had suspicious problem of impossible aspiration and easy injection, and you can flush it additionally with a push-stop technique motion with normal saline, or change the intrathoracic pressure, or change patient's position, or let them move with the arms. Sometimes you can already get spontaneous patency of the device. So what we suggest is to flush again with 10 milliliters of normal saline, and document the result, hopefully in 1 in the patient's file. That's the level 1 procedure performed by the nurse alone. Tja, das wäre ein Problem, nicht weiter. Now, if you go to a patient who was in 1 could not become an in 1 as you see here, you have to check for the correct catheter tip position in the lower 1/3 of the superior vena cava of deep in the right atrium. If the catheter tip location is not correct, but only suboptimal and not really fully wrong, it's misplaced, and you have to consider the removal or the changing of the device. If the flushing was okay, you can use a catheter. Here, if the suboptimal position of the catheter tip, or if the catheter tip was a suboptimal location, and it's the first use after the insertion of the device, you will maybe be obliged, you maybe have to remove the damaged catheter and consider also a placement of the useless catheter here. If it's not the first use, but the patient has pain of a subcutaneous swelling during the injection or doing a prior administration of thrombolytics, you have to control the coagulation parameters, and if needed, consider urokinase injection of 3 milliliter over 10-15 minutes. If that's a success, you just flush and you write that it has been what has been performed with success, your urokinase instillation. That was the level 2 intervention. Now, if the coagulation parameters were, if the patient had the pain and swelling on the subcutaneously during a prior administration of thrombolytic therapy, then it's important to order a linogram, and only if there is a normal jet, you will assess the function later on and consider the device replacement if the problem persists. If the coagulation parameters of your patient are normal, you could use urokinase, but here is what you can see sometimes with the linogram with a catheter which is damaged or in a fibroblastic sheet, and there you also have to go to a further point and ask for help. The level 4 address catheters with normal, with a sleeve formation, where you have to consider a replacement or percutaneous sleeve stripping performed by interventional radiology. If the tip is attached to a vein wall of a heart valve, you also have to consider a replacement or a removal and insertion of a new catheter. If there is a thrombus, you can see it's useful to infuse urokinase continuously. In case of catheter damage, it's important to remove it and consider replacement. Did we already had? Now I want to thank you for your attention and also thank the whole team of Vascular Access.
Thank you very much, Margaret. We have just one question. You just mentioned the study that confirms that heparin doesn't work. Have you already stopped to use heparin in your hospital?
Yes, it stopped.
Okay, thank you very much. Thank you all, guys. We have no further questions. It was very interesting and really comprehensive. We know how to move our, let's say, strengths in what direction. And if you don't mind, in case of some troubles, could we connect you with our questions?
Of course, there is an email address, and if it's for someone else of the team, please just mention it, it will be forwarded.
Okay, Andrew, could you add something?
Okay. So, thank you, Margaret, thank you, Thomas, and thank you, Crystal, for your brilliant presentation. Thank you very much.